this comes back to how we look at health-related social needs, where, what impacts someone's health is not just what happens in a 15-minute office visit with a clinician, and being able to look at, if you will, the return on investment of a community health worker who, for example, we had a community health worker when I was leading the community health program at MedStar, where we had a woman who got readmitted to the ER like 17 times in 3 months. We assigned a community health worker to her who went out to her house and realized that her electricity kept getting shut off. So her nebulizer wasn't working for her lung disease, and that's why she kept coming into the hospital. So being able to think about the return on investment more broadly across the ways that you can impact someone's health, I think is key for all of us, for policymakers, for clinicians, for economists, for those who are leading healthcare organizations.
Welcome to Analyzing Healthcare by Scale Community, which is an education-focused organization comprising of passionate global healthcare leaders. Analyzing Healthcare is Scale's podcast series dedicated exclusively to unpacking the myths and foibles that have been directed at US and global healthcare for as long as we can all remember. Is US healthcare broken? The worst in the world? Perhaps, perhaps not. Let's find out together as we invite the thought leaders of healthcare to share their views. I'm your host, Roy Bejarano. Okay, welcome to the latest Scale Community podcast. I am joined by Dr. Meena Seshamani. Am I pronouncing that correctly?
Seshamani.
Seshamani. Okay, I get a B, not an A, but not a C either. So so at least I'll take the B. All right. So
Okay.
it's an absolute pleasure to have you. I'm really excited for this podcast. And that's because of your background. You served as the Deputy Administrator and Director of the Center for Medicare at CMS. So to me, that means you ran Medicare. Is that me being too simplistic? Okay. All right. So that is a big position. That's a lot of responsibility. And I've often wondered who is out there running this beast, this Medicare beast. And now I get to speak to this person. So I'm just full of questions.
Along with an incredible team. I mean, there were like 1,000 people in the Center for Medicare, more than 10,000 contractors. It is a true team effort. And I mean, just a team of incredible professionals who know more about the Medicare program than anybody else in the country.
And so just so everyone understands, Medicare has 65 million Americans, give or take, that
Roughly
this program is
now.
It's gone up.
And it's people who are age 65 and older, people with end-stage renal disease, and certain people with disabilities.
And again, to frame the many different moving parts, the many different leadership positions, different institutions that fall underneath the healthcare auspice across our government, our federal government, that is, ignoring states for a second, just in Health and Human Services, you have the chief of HHS, and then you have in CMS, not FDA, not NHI. You have just in CMS different positions as well, and even within CMS, you find Medicare, which you were running as a deputy administrator. Is that fair? Sort of framing it.
Yes, that's right. The Centers for Medicare and Medicaid Services sits within the Department of Health and Human Services. And within the Centers for Medicare and Medicaid Services, as the name implies, there are several centers. So, for example, there's the Center for Medicaid and CHIP Services. There's the Center for Medicare. There's the Center for Program Integrity. There's the Center for Clinical Standards and Quality. And there's the Innovation Center, which is kind of the research and development arm, if you will, of the Medicare and Medicaid program. And I worked very closely, and my team worked very closely with the Innovation Center as we were driving a lot of innovations and change in the Medicare program.
Hence the connection to Liz Fowler.
Yes.
And within that CMS ecosystem, I would estimate that Medicare is by far the largest, probably Medicaid second, and then the other groups, the other initiatives that you described. Would that be accurate?
I think in terms of numbers of people, Medicaid has, I think, 80 million. Medicare has 68 million. Medicaid is a federal state partnership. So each state, runs its own Medicaid program in coordination and under the auspices of, the federal government. Medicare is a federally run program. So, at the Center for Medicare, we were the point for all policy making and payments operations for the program.
Yeah, so from that perspective, and I should have qualified that a little bit or clarified it a little bit more. When I think about it as a federal institution with employees and responsibilities, because I was thinking Medicaid is mostly state-run, but the federal government acts as a partner, certainly from a funding standpoint, that Medicare as an administrator, as someone responsible for that responsibility, you're probably employing a great deal more than CMS Medicaid department. Is that accurate?
I don't know that I would, say one way or another. I think they are
Okay.
both very important programs, and each has their role as we think about how do we provide access to healthcare for millions of people in our country.
Yeah, no, I'm neither here nor there. I was trying to get at size, sort of just managerial
Well,
responsibility, but
we partner with more than 1 million clinicians, more than 6,000 hospitals. About 98% of clinicians participate in the Medicare program. As you mentioned, Roy, we provide healthcare coverage for 68 million people. It's about $1 trillion in claims each year. So Medicare is the nation's largest payer.
yep. And might be interesting. Again, this is just me brainstorming, just in terms of data management, because it's housed in the federal government, Medicare, whereas Medicaid is a partnership with all these different states. I would probably suspect, but this is me guessing from the outside, that analyzing Medicaid data might be a little bit easier than rummaging through different Medicaid programs across different states and finding the wide variance and implementation of Medicaid. But I don't know. That's a question.
There's definitely a lot of data that is available with the Medicare program. However, one of the things that I really worked on was how do we improve transparency with the Medicare program and particularly with Medicare Advantage, because Medicare has two aspects to it. There is traditional Medicare, which is run by the federal government, and about 50% of people choose traditional Medicare. And then you have Medicare Advantage, where the government pays private health plans to administer Medicare benefits to enrollees. And there certainly are opportunities for improved transparency across the entire program. And in particular, there are areas that we identified in Medicare Advantage, especially around supplemental benefits, where health plans provide benefits in supplement to the core Medicare benefits, and getting a better understanding of what benefits are being provided, how they're being utilized, and what kind of impact they're having on the health of enrollees.
So many ways we can take this conversation. So that's my task for today, is just staying organized about the many different topics I'd love to ask you. So I'm doing that real time as we speak. First real question for you. If you look at the time that you spent in that position, primarily responsible for primary point of leadership and authority over the entire Medicare program, just at a practical level, you wake up every day, you go from Monday through Friday. If you look back at that position, where did you spend most of your time? What occupied the vast majority of your analysis, your insight, your care? Such a wide terrain of things going on and things to think about. But was there a certain initiative that took up more time than any other?
Well, I think to your point, the Medicare program has incredible reach in terms of the number of people it touches, in terms of the issues that it has the ability to address. And so, in terms of issue areas and initiatives that we focused on, there really were three. The first being, how do we transform care so that it really is caring for people and not just treating a disease? Before I took the job leading the Medicare program, I was taking care of patients, and I saw firsthand how if the healthcare system is fragmented, people can fall through the cracks. And so, for example, Medicare now, for the first time ever, pays for community health services, pays for care navigation. We created new payments to integrate behavioral health into primary care. So again, really trying to, care for people in their communities in the various settings that impact their health. A second big area that we already touched on a bit is Medicare Advantage. How do we make sure that that program is achieving its potential? We tried to make the program easier to navigate. We rejected more than 1,500 misleading marketing ads during Medicare open enrollment. We also streamlined prior authorization so that people can access medically necessary care. And as I mentioned, really tried to bring more transparency and accuracy in payments to the program. And then a third big bucket was around prescription drug affordability. Under my tenure, the Inflation Reduction Act passed, which brought some of the biggest changes to the Medicare prescription drug program since its inception in 2003. So we stood up the first ever Medicare drug price negotiation program and successfully negotiated the first 10 drugs, saving Medicare $6 billion and saving people with Medicare prescription drug coverage $1.5 billion out of their own pocket. And we also implemented a $35 insulin copay cap, an overall out of pocket cap of $2,000, free recommended vaccines. So lots of changes there. So those were kind of three substantive topic areas of what we focused on. But I think another part of your question is, how do you go about doing that? And, I looked at my time as director across, again, kind of three main aspects. First, how am I caring for the staff on the Medicare team? They have such incredible expertise, depth of knowledge. When I first met them back in 2021, I did a Zoom webinar to introduce myself to, all of the people who were working there. And I thanked them for everything they had done during the COVID pandemic because I was helping to lead COVID at MedStar Health, a big health system in the DC area. And I said, all of the waivers that you all put into place really enabled us to do what we needed to do to address the issues of the pandemic. I said, and with that, moving forward, I'm really excited to work with you on how we address disparities and how we improve health equity. How do we drive innovations in care so that we're really caring for people? And how do we make sure the program is sustainable and affordable? And within a few weeks, I had two deputies, one on the traditional Medicare side, one on the Medicare Advantage side, and they gave me Word documents with columns for those priorities that the staff had populated with all of their ideas. And that really is what became our strategic work plan moving forward. And so it really was, being able to spend time internally with the team to hear their ideas, their thoughts, to troubleshoot and problem solve issues as they arose. That was one bucket of where I spent my energy. Another was externally, to take the example of when the Inflation Reduction Act passed, those were some incredible changes that we had to implement in a very, very short time frame. I met with health plans, with drug manufacturers, biotech, patients, clinicians, hospitals. What are the things that matter to you here? What are the things that you want to make sure we know as we are implementing? And I think having that engagement is so key because you learn from people, from their perspectives and their experiences on the ground, both as you are creating policies and implementing programs, but then also on the flip side, that once we had put in place a policy, I was talking to people and saying, okay, we have now put in place, for example, payments to support training for family caregivers, which was something that a lot of people had spoken with me about. I said, okay, now those payments are in existence. You need to make sure they're utilized. Family caregivers should advocate when they go to their loved one's doctor. Hey, I really need help with X, Y, and Z. Can you provide the training? And similarly for healthcare providers, for them to know that these payments are available so that they can start providing services that they want to provide. So that external engagement really, is a two-way street. And then the third area that I really engaged was across the spectrum of policymakers, from the Hill to members of Congress to other parts of the administration, other departments, the White House, to make sure that we were all on track, coordinated, aligned in our priorities and the work that they were doing. And so I think that's how we were able to accomplish what we did, that I'm very, very proud of.
It does sound like, really, to a great extent, a large part of a wonderful mission accomplished, which is getting the Medicare program to improve its range of solutions, refine some of them, improve others, listening to your own team's suggestions in shaping, molding a strategy, and executing on it. So it's not every day that I feel sort of the emotional need to want to actually give my guest a round of applause. But there
Well,
it
it's
is.
really for the team and it's for everyone who worked with us, honestly. I mean, I would tell the, people I'm meeting with, there's no pride in authorship here. A lot of the things that I've been telling you about, Roy, I didn't come up with those things sitting at my desk,
I'm
in the
starting to see
Hubert
how
H.
you got the
Humphrey
position.
building in Washington, D.C. A lot of it was I got to travel across the country and meet with clinicians and meet with hospital administrators and meet with, biotech executives and hear from them what's working, what isn't working, get their ideas of what we could do to improve things. And so really it was a very much a team effort.
Lovely to hear it. Starting to feel and see how you ended up in such a position of importance. And it's not me sort of bloviating and just stroking for the sake of stroking. I have literally sat in this seat and thought about the strategies that you went and solved for. It was years ago, thinking, when will insulin pricing stop
Hmm.
inflating in such a way that it's dragging down the average US citizen resident's quality of life? It's interrupting millions of people's quality of life, this runaway train of insulin inflation. When is someone going to do something about it? When is someone going to do something about the 3 to 4 times multiple on average drugs across the country relative to other countries? When is someone going to do something about that massive problem? We have these challenges in America. Anyone who's interested in the history of our country will look at certain problems that have been problems for decades and wonder, why aren't they being solved? And here you show up in your reign as director, in your tenure as director. And forgive me on the terminology. I'm not used to thinking in those terms. Government institutions. It's new to us at scale. We've been very private sector. I've been private sector my whole life, so just even the terminology is new to me. But what you were able to achieve in your tenureship, if I can call it that, is really remarkable. So once again, round of applause. Back to the questions. Okay, so is it right to think of Medicare as a payer? Fundamentally, it's not necessarily a provider. It's not really engaged in employing clinicians the way that the VA might be both a payer and an employer and a deliverer of care. I went through a long conversation with David Shulkin about what it means to employ hundreds of thousands of clinicians across the country. So if you are truly a payer, could you I would imagine that you looked at the rest of the payer ecosystem landscape and thought about commercial payers, the Medicaid program, the not just Medicare Advantage, but Medicare shared savings, whatever was coming out of CMMI, self-insured employers, overseas payers, overseas governments, self-pay by patients, which you find actually quite significant in certain specialties like veterinary and dental. You looked at all these different sources of paying for care and compared Medicare to them. What did you like about these other forms of payment, commercial payers, whether traditional, sort of fee for service, whether a little bit more informed, like managed care? What did you like about Medicare versus these other alternatives? And what would you critique about Medicare versus these other forms of payment?
Well, I think they are unique programs, right? Medicare is really three levels. There's the Medicare law that Congress, passed and makes amendments to, and that is at a 50,000 foot level, in terms of what are the authorities that are then given to, the Centers for Medicare and Medicaid Services to be able to implement the program. And that's where the second level is, where we put into place regulations at like that 25,000 foot level, providing the guidelines for how the program will be administered and run. And then you have how care actually plays out on the ground, where you have health plans and hospitals and clinicians who are providing the care. And that is a unique construct for Medicare. Commercial payers, they have regulations that they follow, and they have laws that they follow, and then they implement. But you don't have that nationwide scope like you do with the Medicare program. And I think as a result, a lot of people look to the Medicare program in terms of what they are doing. There are many payers, for example, other commercial payers, they use the codes that the Medicare team develops for various services. And you mentioned the Medicare Shared Savings Program. That is a value-based care model that sits in Medicare, that my team and I ran, that provides a wonderful example of how we can try to bring providers together into a holistic care model where they're held accountable for cost and quality. And there are many others who have replicated that model, who have made additions onto that model, and they would come to me with ideas. Hey, there are things with the way that Medicare Shared Savings Program is working that may not be encouraging, for example, smaller providers in rural and underserved areas to come in. And we took those ideas and then made improvements. So, for example, now there is an advanced investment payments program where smaller providers can get money up front from the Medicare program to invest in their infrastructure so that they can become an accountable care organization. So, there were things like that where there was quite a bit of back and forth of learning from each other. And similarly, back and forth with the Innovation Center. We took many ideas that the Innovation Center had developed and had tested, and then we scaled them in the Medicare program when they worked. A great example of that are some of the changes that we made in paying for care navigation and for community health services. These are things that had been tested in the advanced primary care models of the Innovation Center, and now it was time to scale them in the Medicare program. So I really think it was a lot of back and forth, also understanding that different programs are going to have differences, but how can you harness the learning of what's worked in one program to improve another?
Well, I'm interested in pricing. I'll jump into
Mhm.
that for a second. Again, it's such a hard interview for me because every time I want to ask you a question, I have to delay asking you two others. But I'll do my best to persevere. All right, let's go with pricing. So, as an ignorant on the outside, wondering what's happening on the inside, I've grown up. It's just 15 years for me in healthcare. It's not that long, but for the entire 15 years, it's always been Medicare pricing influencing commercial payer pricing, which in turn influences decision making by providers. And so the origin of everything seems to come from Medicare. So you walk in the door on your first day, you're director of Medicare, and you walk through the halls, and it's almost like Charlie and the Chocolate Factory. You open a door, and I imagine 1,000 accountants, actuaries busy analyzing healthcare data in order to fine tune RVU based pricing for hospitals or for outpatient facilities, modify all the different Part A, Part B, Part C, Part D initiatives that Medicare is responsible for, constantly calibrating pricing and then reporting back at the end of the year, whenever the calendar allows, here's our new pricing for this year. And I imagine on the door to the left, the same number of different people going through the same exercise for Medicare Advantage, risk-based pricing, patient risk profiling, bonus incentives, constantly calibrating and fine-tuning what they're learning, what they're getting as feedback from the marketplace. What's the truth of it? It's always the risk that it's sort of a Wizard of Oz scenario and there's just one person in the room. coming up randomly with pricing for the entire industry. How big a department is the pricing department in Medicare? How much of your time did you spend auditing their analytics to see whether you agreed with them or not? Was it really, very detailed oriented, or just you rely on them doing a good job? Did you listen to commercial payer feedback on pricing? I get the sense, very big on engagement. Are you going out into the marketplace and listening carefully to healthcare associations, representatives speaking on behalf of providers and what they're telling you about pricing? How does the pricing ecosystem work within Medicare?
Well, you are asking a great question. This comes back
Two thumbs
to
up for me.
two
I'm
thumbs up.
elevating my
This
grade.
comes back
I'm now
to
a solid B plus.
this comes back to the different levels that I mentioned of Medicare. And quite a bit of the fee schedules are determined by Medicare law, where there are formulas that we have to use. There are things that we have to follow in terms of, what the pricing is. In addition to that, so one of the key areas there in the physician fee schedule, for example, there is something called budget neutrality, where overall things have to be budget neutral. So if you're increasing payments in one area, then payments get decreased in another area to stay budget neutral overall. Congress also determines what's called something called a conversion factor. That is set by statute that determines ultimate, payment levels in this formula. Um, and then there are other sources of data. You mentioned RVUs. So we get information from the American Medical Association, for example, who, helps to determine RVUs and gives us information that we can use for our pricing. We also get cost reports from hospitals because that's what we use to base a lot of hospital payments on. It's on how much are they spending in resources for various services so that we can reimburse them appropriately. So it's a variety of different inputs that are, again, under this overall umbrella of what the statutory or legal authorities are in the Medicare program for what Congress has said, this is how you can pay. We do auditing. We do auditing of health plans, of drug plans. We also have our Center for Program Integrity that audits the claims that come in from, billing providers. So there's quite a bit. And the oversight and auditing is not just on the payment side. I mentioned to you, for example, about how we did a lot of work in Medicare Advantage around prior authorization. When people, need to get a treatment, and the clinician has to go to the health plan to say, hey, this is needed, we need to get this. And we found that there were a lot of barriers and hoops that were being created for people to get medically necessary care. So we streamlined prior authorization. Basically, if something is covered, has a coverage decision in traditional Medicare, then the health plan has to follow that. They cannot add anything further. If there isn't a coverage decision in traditional Medicare, then the Medicare Advantage plan has to use well-established clinical guidelines that are publicly available as they are determining whether to cover something or not. All of those things also entail oversight and auditing to then make sure that people are following it. So oversight and auditing is a very important part of the work we do. And yes, we have many teams who are working through the pricing each year. And the pricing comes out in the fee schedules that, again, is determined by law. There are like the physician fee schedule, the inpatient prospective payment system, there's home health, there's hospice, outpatient prospective payment system, and all of these come out on a regular basis as determined by law because there are deadlines in Medicare law as to when these fee schedules need to be released.
Okay, so now that we're talking about pricing, I'm ready to talk about drugs.
Yes, that's a whole separate aspect of pricing.
You see how hard
The
this
last
is for
thing that
me.
I would say on the, the other, more parts A and B services that we were talking about, in institutional and outpatient settings, is that all of our fee schedules go through notice and comment rulemaking. So that means that we do analyses, we put out a proposed fee schedule, and then there are 60 days for people to give comment. And that's when we get a lot of information and feedback, data on, is this an appropriate price or not? And then we incorporate that when we finalize pricing. So there is a
That's when the
very
lobbyists get to work and their
there's a
associations.
very set
Feed me, no, feed
process
me. Yeah.
that is utilized to make sure that this is a thoughtful, deliberative process.
Yeah. All right. Drugs. So I feel like I frequent Barnes and Nobles regularly, bookstores, and you look at the first bookshelf and it's always the books that just came out. And sometimes occasionally there's a subject that's out there and the book hasn't been written yet. So I feel like what you did for Medicare and drugs is a book that needs to be told. It's a story. It's almost like a movie. It has sort of suspense to it. So if I was a director or a writer of this story, I'd start with state level enacted laws tackling drug pricing prior decade. So California, Nevada, Oregon, Vermont, all around 2016 to 2018, introduced drug manufacturer price disclosure laws, restricting price increases, trying to clamp down on this question of drugs in America. Then I throw in the antagonists, right? The bad actors. And for me, this is my first question on drugs, but I have so many for you. I find it unbelievable as just a reader to see the following stat. 3 PBMs represent 80% of drug purchasing in America. Caremark, OptumRx, and Express Scripts. 3 names that the average American wouldn't know. But what I find even more amazing is that every single one of them is owned by a payer. So CareMax is owned by CVS Health, OptumRx is owned by United Health, and Express Scripts is owned by Cigna. CVS includes Aetna. And so what that tells me, and again, this is a question, this isn't a statement. I didn't write the book. I haven't done the research. Can't take credit for knowing too much. I wish I could, but I can't. What that tells me is that 80% of the drug purchasing is performed by payers, which on its own sort of makes sense to me if payers are really incentivized to be payers, which is to manage costs. However, these PBMs have made a lot of money, and I'm not going to hop on their CEOs getting paid $20 million a year as PBMs. Maybe they earn it. I don't know. But I do know that their P&Ls as PBMs are enormous. And it turns out part of them making money is when more drugs are bought by us consumers at higher prices in the form of rebates, which you would think a payer paying for healthcare would object to. Oh, I want to pay less. Unless the payer is benefiting by owning the PBM. In that scenario, it seems like they're winning either way. If drug prices go up, they get more rebates, Mr. and Mrs. Payer. If they go down, then their utilization of healthcare goes down and they earn more of a margin on the difference between premium and spend. So they sort of are playing both sides of the casino table. And they can win both with heads and with tails. Am I understanding that correctly? It seems like it could only be inflationary, that system. And so someone outside of that system, like Medicare, negotiating drug prices would end up with a very different result, which is why I think it was the Inflation Reduction Act of 2022 suddenly creates a brand new negotiator for drugs in America that can actually drive pricing effectively for the rest of us. I'll stop there.
Well, Roy, you raised a few different issues in
By the
my
way, Mark Cuban is eagerly on the edge of his seat, eager to hear what you have to say about this topic. He's been emailing me incessantly. Got to get Meena to talk about drug pricing new laws because his cost plus business is entirely an offshoot of this. So,
well, and I would say this is another example of how Medicare law provides or does not provide the Medicare program with certain authorities for regulation. And, pharmacy benefit managers, that is an area where Medicare does not have regulatory authority. That's why there has been a lot of conversation in Congress about, about the level of transparency with PBMs. How are rebate dollars being utilized, and are they, are they to the benefit of the enrollee? Those are questions that are really with Congress in terms of what authorities they would then want to give to the Medicare program. What the Inflation Reduction Act did was it gave Medicare the authority to be able to negotiate directly with the pharmaceutical companies. And, you mentioned something about bad actors, good actors. I will say that as a health economist, so I'm a physician, I'm also a health economist. Market organizations respond to markets. It's econ 101, and healthcare markets are imperfect. I won't derail us into a whole conversation about asymmetry of information and, the high cost of entry and exit and supply induced demand and moral hazard. But suffice to say that healthcare is not a traditional market where you have someone going to the grocery store, they know exactly what they want to buy, they pay for it with their own money, they get their own benefit from it. This is a triangulated system with many different players, and the patient oftentimes is not the one who has the information to know what is needed. The patient is not the one who is paying most of the bill. And so because of that, it was really important for me in standing up the negotiation program to really meet with everybody involved in drug pricing and to say, hey, what is working and what isn't? And I think very quickly there was a common goal that crystallized that everybody wants access to the innovative cures and therapies that people need. People go into biotech, into pharmaceuticals, because they want to provide new treatments that people can utilize, not ones that are going to sit on the shelf because someone can't afford them. And they also want to be rewarded for those innovations that are first in class, that are providing a step change in the ways that we can treat and cure disease. Obviously, from patient perspective, they want to continue to have innovation. They want to be able to access it. And for clinicians, they want to be able to provide the care that people need. I mean, I had a woman who came to me because I prescribed an antibiotic that she couldn't afford. And we got on GoodRx, and I was trying to find an antibiotic for her that she could pay for. So, I think that really formed the foundation of how we set up the drug negotiation program. And from that point of negotiating the drug prices that Medicare did, that then feeds into the system for the prescription drug plans where they can do further negotiations with pharmaceutical companies. The analysis that we did that showed that if those prices that we negotiated had been in place in 2023, it would have saved $6 billion. That is on top of the negotiations that the PBMs, the pharmacy benefit managers, had already done. So again, demonstrating the success of the program, but I think just as importantly, bringing some transparency to bear, where we put out a guidance saying, here's how we're thinking of doing negotiation. Give us feedback on the negotiation process. Then we had patient-focused listening sessions where we got information from people taking these medications. We had meetings with all of the drug manufacturers. And ultimately, we published the narrative for each drug of how it was negotiated. That is transparency that does not exist when you have, a pharmacy benefit manager negotiating with the pharmaceutical company. And the hope is that in doing so, more data is being provided as to the value that drugs bring, the benefits that they provide, and a way to think through how pricing can work in a data-driven way.
Introducing Medicare into drug pricing discussions is such a win because you've played the most critical role in healthcare in America as a price arbitrator for healthcare, except for drugs. And the difference, if you look at our cost curve since 2009, fully bent 17.5% of GDP, other than COVID, and then corrected back post-COVID, hasn't moved from 17.5% of GDP, which means just mathematically, you're an economist, the rate of inflation of healthcare in aggregate has been the rate of inflation for the US economy. It still occupies 17.5 cents on every US consumer's dollar, which is great news. But drugs have continued on without Medicare supervision, inflating at exponential rates and keeping us well above the rest of the world in terms of inflation. What I find interesting also as an amateur economist is when you look at all industries at moments of price perversity, right? When pricing, not just the signals, the pricing itself is upside down and anomalied, and to a point where it's destructive. It's eating up wallets of individuals. There's always representatives from the given industry that will argue for that indefinitely. There's everyone's sport for choice in terms of arguments. You can make an argument about anything. The number of arguments made to justify why US drug prices are on average 300 to 400% higher than anywhere else in the world is a long list. And we could have kept going for the next 50 years. So I do think Medicare entering this sphere, finally, my one complaint is, I wish, Meena, you'd been in charge 20 years ago. Because we would have saved, if we saved $6 billion in 2023 or 2022, it would have been 10 times 6, 60 times 2 is $120 billion of savings over the last 20 years, to be crude about it. And those savings come out of individual wallets, their employers, their employees, their patients. It's just lower cost of living. And you do see a lot of the dissatisfaction among citizens is a function of how much things cost. There's a lot of frustration with cost of education being inflated at 10% per year for the last 30 years. It's a lot of frustration with that. There was a lot of frustration directed at healthcare. So this was a big win. And I do think we ignore the things that we're doing badly in society until they overrun us. And I think we also ignore the things that we're doing well. And if I had my wish, we would come back to Medicare and drug pricing every year and report back widely to the public the benefits of good policy, redirecting us in a much better direction. What do you think of some of the new actors in drugs that are focused on transparency and pricing? Obviously, my new friend Mark Cuban, Cost Plus, but GoodRx as well, Amazon. Is this a net benefit to society? Are you excited for these new entrants? Good competition? Are they going to struggle with meaningful barriers to entry and all the entrenchment that the PBMs have around them and the payers that actually own the PBMs? What are your thoughts on those new entrants?
I mean, I think that a healthy market is a market that competes on what matters to people. And a lot of what I did in the Medicare role was, how do we make sure that the healthcare market is competing on access, quality, affordability, and how do we bring more data to bear so that people can navigate with the choices that they make as healthcare consumers? So whatever form that takes, on the provider side, on the drug side, on the health plan side, I think that is the key, is that you have a competitive market that's competing on what matters to people. And Roy, I want to pick up on something that you were saying about the price of drugs having increased, in recent years. One of the other aspects that I think was really important of what we did in drug price negotiation was say, the thinking about healthcare costs is not just in some silo, right? A drug can cost a certain amount of money, and maybe it is keeping someone healthy so then they're not getting hospitalized. So they're not going to the emergency room, and really being able to think more broadly about healthcare and about the economic implications of when someone is sick and when someone stays healthy. So I think that's another aspect to all of this that I hope that conversations can continue. This comes back to how we look at health related social needs, where, what impacts someone's health is not just what happens in a 15-minute office visit with a clinician, and being able to look at, if you will, the return on investment of a community health worker who, for example, we had a community health worker when I was leading the community health program at MedStar, where we had a woman who got readmitted to the ER like 17 times in 3 months. We assigned a community health worker to her who went out to her house and realized that her electricity kept getting shut off. So her nebulizer wasn't working for her lung disease. And that's why she kept coming into the hospital. So being able to think about the return on investment more broadly across the ways that you can impact someone's health, I think is key for all of us, for policymakers, for clinicians, for economists, for those who are, leading healthcare organizations. And that's where I think the conversation needs to continue to head.
We're not going to get through it all, which I'm realizing that right now. I'm going to have to irritate you for another podcast because you're so right. If you'd shown up and Medicare now had authority to negotiate all drugs, not just 7 drugs, but all drugs,
It was
your
10.
job
Now it's 15.
10, good, 15, hopefully soon 25.
It goes up to 10.
Um, I'm thrilled. It's good news. It's not like your job is done. So there's just that's part of the beauty and the challenge of our industry. Very complicated, um, and because of all those strange black box dark corners of obfuscation, when you attach obfuscation to a private market, you get perverse outcomes every time in every industry. Sometimes intentional, because bad actors can get away with stuff because nobody knows, they're in the dark. Sometimes mostly unintentional, because it's the no one knows what the hell's going on around here story. And that's just, you see it in so many places. My experience of industry, I've worked in several industries before healthcare, is that it's, especially in this country, but in most countries, mostly full of good people trying to create value. Otherwise, they won't get paid. It's almost like business is its own religion. It creates goodness, fair trade. But if you sprinkle darkness and confusion on top of that, you'll still get bad outcomes. So you look at some of the issues that we have. We have monopolies. We have local monopolies all over healthcare. You pick a state, you're going to find a payer with plus 50% market share. When Hart-Scott-Rodino is sensitive to transactions that might exceed 5-10% market share because they might be overly powerful and influential. All over healthcare, every state has a payer monopoly inside of it. You look at certain regions, you'll find one hospital monopoly after another. Those hospitals typically owned by a health system. Those health systems have a lot of control when they get to 50, 60, 70% market share for the given service that they're offering. We have a long way to go with undoing monopolistic behavior, again, reinforced by all kinds of arguments, but ultimately leading to perverse outcomes. We have disparate data everywhere. We want to make sound decisions about what's going on in healthcare, and a lot of our data doesn't speak to each other. It's non-interoperable. By the way, recently, US versus UK healthcare was highlighted to me in a podcast by the former head of the ACO National Association, who's a big fan of yours. And he pointed to European healthcare as at least excelling in that regard. Single payer, single EMR. I just came back from England. Apparently not true. Single payer doesn't equal single EMR. They still have in the NHS many EMRs, many different systems. They don't talk to each other. They're all antiquated. It's heavy underinvestment. So interoperable data is a challenge everywhere. Dealing with these complex reimbursements, value-based care program, correct incentives. I've heard of real skepticism towards some of the Medicare Advantage program being maybe too generous to too many operators out there, without necessarily enough savings being realized. And then an arrow pointed at the Medicare Shared Savings Plan as being the real deal when it comes to coordinated value-based care. And then the critique being silver sneakers as an example of strong in consumerism. You get patients to sign up, get members to sign up, but not necessarily as strong as it needs to be in terms of outcomes. So just wrestling with that issue. The biggest issue of all, as you said, Meena, preventative care. Health versus healthcare. This is a big theme for me. We have a long way to go in health. We might have the best healthcare in the world, but if we have the worst health in the world, it almost doesn't matter. That we have great doctors, the most well-trained doctors, the most investment, the most innovation. It doesn't matter if our health is dreadful. So just where to go with all these topics and how to think about it globally. Which of those topics do you spend more time on today? You're about to become the Secretary of Health in Maryland. So maybe your world goes from all of America, 350 million, to Maryland. How does your job change, and how do you think about those many different challenges as you enter this new role?
I mean, I think it's a lot of the same themes. How do we make sure that the system is caring for people. And I think states have a unique opportunity for that. You are closer on the ground in terms of partnering across the settings that impact someone's health, from food to housing to the justice system. And I really look forward to all of those partnerships. And I think to the points that we were raising, how can we better harness data and transparency and thoughtful decision making? How can we make sure that the market is competing on what matters to people and make sure that it's a competitive market? I think a lot of those themes carry forward in a state setting as well, with the opportunity to really be a laboratory for innovation. And Maryland has a unique payment model. It has an all payer payment model that sets global budgets at the hospital. So it is not a fee for service model. It is saying, look, here there will be a sum of money and you manage the patient in the best way that you can, which I think is where a lot of the work that I did at CMS was trying to get everybody else to. So I think it's really a unique opportunity to be able to continue to innovate, to drive population health, to move care upstream so that you're really keeping people healthy and you're spending the healthcare dollar in a smarter way.
So Maryland looks quite unique here. And I wasn't even aware of this. Medicare, Medicaid, and private insurance all pay the same rates for hospital services, regardless of hospital. The state is regulated by the Health Services Cost Review Commission, HSCRC, an independent state agency. Do they also, I imagine they include drugs in that. And so you don't have any
There
variance
is
in
a
price.
separate prescription drug affordability board.
Okay. And then you don't have variance in pricing across hospitals, which is just amazing. I
So
think
it's a unique
unique. It's
model
one
that
of one.
enables testing of innovative ways to treat people.
And then on top of that, it has total cost of care. So it's capped. Um, is it risk-based as well? Are there bonus incentives attached for savings? So is it
There are
really
various quality programs.
yeah,
Yes, there are bundled payment arrangements, et cetera. Yes.
okay.
Readmissions, there are programs to reduce readmissions. Yeah, so I think it'll be a very exciting time and something that we will work closely with our CMS partners on as well. Because again, I think with Make America Healthy Again, the focus on prevention, on addressing chronic disease, on the importance of nutrition and good lifestyle, a healthy lifestyle in keeping people healthy. Those are all things that I think the Maryland model really enables innovation and to be able to think about care outside of, okay, somebody comes in to see you, you give them a diagnosis, you give them a prescription, you send them on their way. Instead, it's this is a person who lives in a community. What are the various things that are impacting this person's health? How do we bring all the resources to bear so that we can most effectively support this person?
And it is interesting. I'm looking at the stats. One of my, it's more than a pet peeve. It's a structural, fundamental issue with how we go about analyzing our own industry is life expectancy, which I think is sort of the crudest data point because it aggregates all of us into one bucket and ignores other considerations like access to care, like obesity levels, investment in care. Every state is different. Every neighborhood is different. More Medicaid, less Medicaid, more birth rate, higher birth rates, lower birth rates. Everything is different. Age of population, income levels of population, and so every neighborhood has an opportunity to improve. So as you look at Maryland, average life expectancy is 77.2, so I'd call it average. Obesity levels, middle of the road. 23 out of 50 states, 34% obesity. So as you look at those stats, and yet Maryland's delivery of care, and its incentives, its reimbursement program is totally unique in the country. Fast forward 5 years from now. Let's say it's a really happy 5 years for Meena at Maryland, and you get your wishes. You get to do 2 or 3 transformational things in Maryland. What do you hope to achieve from a KPI standpoint? Because I think it's a tall order to say Maryland's going to be first in the nation in life expectancy. So what are the KPIs? Is it lowering rates of healthcare inflation? Is it all Maryland citizens, all Maryland residents have access to care? Is it a KPI that we never talk about in America because we don't know any other way? We're like children, and this is our only house that we've grown up in. But waiting lists are a huge issue in the rest of the world. It's an average, it's an 8 million citizen waiting list in the UK. And I think of the 8 million, the average is 12 months. So that is the number one topic, KPI, for healthcare in other parts of the world, waiting lists. So when you look at Maryland, what do you hope to achieve over the next 5 years?
Well, I will start by saying that I have not started the role yet. And I think, a theme of what we've been talking about, Roy, I need to meet with people on the ground. I need to
Well
walk
said.
the walk.
Learn first,
I
do
need to
second.
learn. I need to talk with this team in the department, patients, clinicians. I think ultimately at a high level, my goal is that, the Department of Health is taking care of people from the moment they are born until the day that they die. And how can we most effectively do that? And how can we do that in partnership with the sister agencies, to really care for people so that they can live full lives? So that is the high level goal. And I think in terms of where exactly the opportunities are, it was the same in Medicare, where I came in and I said, look, this is kind of what I would like to do. And then the team helped figure out those details, and meeting with stakeholders enabled us to figure out details, because then you get the perspectives of people on the ground. And that's very important.
The right answer. Absolutely. So look, I was thrilled to speak to you. It's been an hour. I would go another hour, but I think it's weighty topic. So I have to leave you feeling good enough to want to do this again.
Well,
Because
thank you so much for having me.
such big questions that we haven't delved into, like Medicare Advantage versus Medicare shared savings. So much cool stuff for us to dig into again. I can't believe what you've been able to achieve, one person. Really, really, really round of applause to you. And so excited to stay in touch with you and hear how things go in Maryland. You're a gift to healthcare in America. You really are. We're lucky to have you. So there's a lot of people now listening to our podcast. They're going to be thrilled to listen to you. And I just, on behalf of all of them, we're grateful. Thank you, Meena.
Well, thank you.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.